Pejman mentioned, I'm a physicist at GenesisCare and then a PhD student at UWA. So today this is kind of my presentation from my UWA side. And I'm going to try and give you a kind of high-level overview of what we've done from the PhD over the last few years. So basically, as the title would suggest, it's based on spine stereotactic radiotherapy, which is kind of high-dose, high-conformal treatments to spine targets, either primary or most commonly metastases, which we have in the spinal vertebrae. And so where we particularly looked at this was during the rollout of this within Genesis. So we have a very clinical context, and it's very clinical driven, more so than kind of a pure research or novel kind of approaches. And so we looked at a little bit, we're using a Monte Carlo calculation algorithm within the Monaco TPS. So we looked at some of the complexities related to using Monaco and Monte Carlo algorithms. We also wanted to explore a little bit about spinal stabilisation devices, which were previously for us considered a contraindication to spine SBRT. So we wanted to investigate whether we could reduce that and treat these patients and look at some of the new materials that were coming through for implants. And then we wanted to kind of also bring that into the Genesis, or I guess, and also kind of some of the more modern eras of using match Linux across multiple departments. So we looked at how reliable this technique can be rolled out in a kind of multi-Linux environment, either spread across multiple departments or multiple Linux within a department. We'll try to kind of quantify what you need to consider if you're using different Linux on different days. So these are the kind of 4 aims we focused on. So we wanted to evaluate the Monte Carlo algorithm calculation parameters, specifically the kind of variations that you see between dose grid changes and statistical uncertainty, which is a kind of Monte Carlo inherent and specific kind of challenge that we focused. And then we wanted to look at the best way to go about the commission of these techniques, how we can use small field detectors to kind of verify these doses accurately, and then move on to the idea of a kind of distributive QA model, which we'll come back to a little bit, but this is focusing on how we can use different Linux for treatment QA, and we can move patients around to make it optimal for them. And then we went on to evaluate kind of implant-based approaches. So we used some 3D printing, some spine phantom, and got some immobilization devices to test. All right, so we'll start off with the Monte Carlo calculation parameters. So for those that aren't familiar, so Monte Carlo is kind of generally considered the gold standard of dose calculation. And it uses a simulation-based approach to determine dose rather than a pure calculation. So we've got a pretty rough diagram here, but what we see is what we do in Monte Carlo is we simulate the electrons or the photons that exit the Linac head, and then we track them through the patient and we model their likelihood or probabilities of interactions at different points. And that's done based on known interaction probabilities of the different photons and electrons and the different particles as they travel through. So the way, instead of completing a calculation and resulting in a dose, what we end up here is with the actual simulation, which means that every time we run one of these particles through, we get one track or one history, and then we have to keep doing more and more and more to kind of simulate what would be done in a real world situation, and then we determine the dose at different locations within the body. So we like this from a physics perspective because it's kind of simulated from first principles rather than calculated with any kind of underlying assumptions or approximations. Theoretically, in reality, these have some assumptions made, but fundamentally they're there. So what this looks like in the context of a spine saber case is that the more histories and more particles we simulate, the more realistic or the more representative of the true dose this like the positive distribution will reflect. So what you kind of see is as we decrease the noise, so we start in the sort of top left there, we've got a lot of histories that have been run, and we get kind of nice smooth isodose lines. As we move down to the bottom right, they get increasingly noisy. So they show the same dose distribution, they show the same pattern, but it's a little bit harder to interpret, and there's more noise within the data that we're looking at in the bottom corner. And that's limited by the statistical uncertainty setting within this clinical TPS. So basically, the more histories we run, the smoother it gets, but it also takes a lot longer. The other thing that we know in all TPS is that we end up voxelizing the patient. So we determine dose at small bins and small locations. And the bigger that gets, the coarser the calculation gets, which is, of course, the problem for spine saber, where we want to look at some very steep dose gradients off towards our core. So what we want to do is make an assessment of these. So we can have a very infinitely small dose grid, infinitely high number of histories, and that's going to give us a super precise calculation with high accuracy. But it's also going to mean that we don't get our patient treated in anywhere near a reasonable time frame, and we can't have the patient throughput that we need in clinical departments. And at the other end, we have very coarse or quick calculations, but they end up being very noisy, and they don't give us a particularly true representation. So what we wanted to do is quantify what the statistical uncertainty setting means in reality when it comes to clinical practice. If you put 1% standard statistical uncertainty in, what does that mean for your dose calculation? How much should you trust it? And then we wanted to look again at what changes in the dose grid and that setting actually do in terms of the reported DVH metrics and how that might influence clinical decision making. And then make some recommendations, ideally, on the best practice. So to do this, we extended it out past the spine patients. We looked at brain patients, spine patients, and lung patients, all in the SBRT context or SRS context. And we considered some of the more major criteria that are used to assess these plans from a clinical perspective. And what we did, in short, is calculate each of these plans at a varying range of dose grids and statistical uncertainties, and then looked at the results. So I won't dive too deeply into the maths here, but basically what we've taken is you look at a given dose level in the plan, and you can calculate on a very fine dose grid and a very low statistical uncertainty and determine what you would call a ground truth. And then we can look at the different dose grid settings and the different statistical uncertainty settings to see how much the dose in a given voxel varies from its kind of ground truth calculation. And by doing that across the cohort plans, dose grids and statistical uncertainties, we can determine the variance or the standard deviation of the doses we expect to see at a given location just by varying the dose grid and, in this case, the statistical uncertainty. And we get some kind of plot that looks like this. So what it shows us is if we set, for example, a statistical uncertainty of 1, we get this dashed black line. It means up at around the relative around the isodoses relative to kind of 80, 90, 100%, we do see a variance of around 1. So the Gaussian that represents the noise within that calculation has a variance close to 1. But as we come lower down to these low isodose calculation areas, we start to see increased variance, which is coming back to the way this is implemented, but the histories obviously predominantly go through the PTVs and targets, and the lower doses and the OARs outside of the field have less history simulated through them, which gives us a greater uncertainty in the calculation. So this is generally quite good for radiotherapy, but it does mean that we need to consider this in cases of like spine or SBRT, where we might have a high calculation accuracy precision inside the targets, but OAR doses that can be in this 30 to 40%, like the cord, do have almost double the uncertainty in them. So these are some kind of DVH parameters or metrics we pulled out, and you kind of see the same sort of patterns. So essentially, as you start to increase the statistical uncertainty, you start to see a broader range of values reported for the given plans. So this is looking at the variation across the different plans for a given statistical uncertainty. And then you also see is the max dose increase, and we see the PTV coverage gradually fall off. And this is, I guess, a function of how we actually extract DVH metrics. So when we start to increase the noise by increasing the statistical uncertainty, it means we have some higher and we have some lower values because the noise range is increased. And then when we look for the maximum dose, we inherently pick those values with the highest noise, which is what we're calling the maximum dose because they're maximum. So it's a kind of false reading, but artificially will project a higher maximum dose if we don't decrease the statistical uncertainty significantly enough. And at the PTV coverage end, the same thing happens. We introduce some more noise. We have higher and lower doses, which means some of those values where we had determined the PTV was covered, those voxels are now not covered anymore. And it starts to cause a drop in dose coverage. And what we can see here is that, as we would expect, the spinal cord doses, it becomes a more prevalent consideration. So I've kept this as the same image from the last time. We can see there's a kind of relatively small changes. We see a much broader change in a much broader bar chart for these in the lower doses, because inherently the statistical uncertainty there is higher because the lower number of histories that pass through that region. So it just means we need to add a bit more consideration or a bit more uncertainty into the calculation of our OAR doses. What is reliable is things that sit near the middle, so things like the mean doses, because we add a bit of higher dose, a bit of lower dose, introducing the noise, then we get to maintain the same mean. And then things like conformity indices and gradient indices are largely unaffected, again, because they're generally ratios, and they kind of balance out the added hotspots and cold spots. So what we managed to conclude from this is that essentially changing the dose grid size is always a bigger effect than changing the statistical uncertainty. And the key thing is that we should make sure we report these dose grid and statistical uncertainty settings next to any calculated DVH, because depending on what you use, the DVH metrics can mean slightly different things or have slightly different accuracies. And we also looked at kind of the variation of what a maximum dose means. So we also need to consider, if we're using a 1 ml dose grid, this 0.35 cc, which is commonly referenced in the literature as a Dmax, is kind of it's quite applicable. If we move to a larger dose grid, we need to probably increase that size as well, because we resort back down to just extracting a single voxel, which happens to be the one with the biggest positive noise. But the key takeaway from this is that to make sure that we can calculate treatment times, this is a pure dose calculation, not an optimization, but a calculation within 10 minutes, and for which we kept 75% of deviations within 2% of the ground truth. We had these recommended values, so dose grids of 1 mil for spine and brain, as a 2 mil dose grid for lungs, and the statistical uncertainty of 1.5 always met those metrics. I should say that this paper was published 6 years ago now, so the increased calculation speed and certainly introduction of GPUs can massively reduce these calculation times, which can also allow us to drive past these. So these really probably should be considered worst case scenarios right now, I think, in current clinical practice. Okay, so the next thing we looked at was TPS correction factors for Monte Carlo algorithms. So this one's relatively physicsy, so I apologize for those on the line that aren't physicists, and I'll try and get through this one a little bit quicker. So the TPS correction factors, what we want to worry about is small field dosimetry when it comes to SBRT or even SRS. And the statistical noise problem that we just talked about kind of extends into this situation, and it makes the commissioning and calculation of small fields more challenging than you would see in a standard TPS. So this is kind of, I guess, a very rough sketch. If you can imagine some kind of standard line here, which has a bit of noise going across the screen. What we want to do to try and determine the mean value of that line is to take an average over a small volume, so that we don't just get a number that's quite so affected by the noise. Now, in a small field, we need to take a small volume to be able to determine an average, but that means we're still a bit more susceptible to noise interactions. If we can take a bigger area, like the one on the right, we can get a much better reflection of the mean, but it means we're averaging over a volume. And this is a problem that we have when it comes to small field dosimetry, and we've kind of worked out how to do that from a measurement perspective. So if you imagine some steep isodose like this, if we measure with a kind of small ionization chamber, we get a value that is much closer to the maximum average value within that box. kind of what the green line looks like, would be closer to the top. And if you measure over a bigger area, I just realized I didn't have that on. If you measure over a kind of bigger area, it drags your value down. So when it comes to measuring these things, there's some really well-defined practices that you use a ionization chamber or a detector with a finite volume. You measure the dose and you can correct that back to a single point dose. But this also needs to apply to the TPS, because in the TPS we can only ever calculate to volumes or to voxels. And in Monte Carlo, what we really need to be able to do is make that volume a little bit bigger to average out the noise in such a way that we can determine a true mean. So here we want to be able to use this big box, calculate an accurate mean, and then correct it back. So what we wanted to do was determine correction factors that could be applied to the average dose in small spheres of calculation. So trying to match what we do in measurement in the TPS to allow the same sort of practice. And this was going to, we kind of see if we're going to derive these correction factors, we need to derive some kind of uncertainty to know how reliable they are. And then we wanted to use this to see if we could determine a way to model a treatment ionization chamber for patient-specific quality assurance. So the TPS correction factors are a relatively straightforward process. So we calculated output factors on 40 different iterations of a water phantom. So they're essentially the same calculation, and they vary only by the statistical noise. What we could do from there is we could determine and extract the dose at a given voxel, so the isocenter dose, for example. And then we could also look at the mean dose to a small sphere. And within the TPS that we're using, at least, as you increase the sphere radius, you essentially just extract more voxels from in a kind of increase in spherical approach. So it's a block-wise sphere, if you like, that it kind of corresponds directly, and we get these jumps at different sphere radiuses. So from the 40 calculations, we extracted the isocenter dose, which we called in the true dose, and we extracted the dose to different sphere sizes. And then you can derive a correction factor purely as what you need to multiply this mean dose to get back to the voxel dose. Once we determined these doses, we then went back through and retrospectively applied them to those 40 different calculations and see if we had have used these on the day, would we have got back to the true value? And then finally, to try and look at the chamber similarity, we took these tables from the TRS report I referenced earlier. So they tell us what the correction factors are when you're using any given chamber. And what we wanted to do is see if we could match these values up to some of the calculated correction factors within the TPS. And that would allow us then to use one of these chambers for measurement and use the same size sphere within the TPS without having to apply corrections to either detector or calculation. These are relatively bland charts unless you're actually trying to use them at the time, but we successfully derived some correction factors. And what we could see is that kind of for these small fields, the correction factors are really quite low until we start moving into this kind of 12, 10, 8 millimeters, the real extremes of SBRT or SRS. And fundamentally, when we get down to kind of 4 or 5 millimeter fields, these factors become really quite high. They exceed 5% pretty quickly. So that's probably not a useful area to use them in. And then we have a corresponding uncertainty and the kind of increase in sphere radius versus so it's kind of, I guess, 95% of points we'd expect to be within this error. And we could see they were relatively good. We could generally find a combination where the sphere size was big enough, we could apply some averaging and apply a correction factor to determine the calculation value within kind of 1%. But again, when we drop down to this kind of 4, 5, 6 millimeter radius, this technique really doesn't hold up anymore. So when we try to then use this to model correction factors, what we've got in this plot is correction factors for a CCO1 chamber. These black circles. So we know that that's what you need to correct a measurement by. what we could kind of say is that they most closely follow this yellow line, which is a 1.8 millimeter sphere radius. So in theory, we could use a 1.8 millimeter sphere radius in a TPS, and then we don't need to correct our measurement and we don't need to correct our calculation, and it kind of averages out. For the CCO4, it follows this 2.9 millimeter line. And that's interesting because these values are both significantly bigger than the ionization chambers, so that means that something a bit more complicated is happening in that case. We then went back through, we had just over 80 cases that we'd measured, and we looked at the agreement between the measurement and the calculation, depending on the different sphere size. And we did see again that the mean, or the median in this case, difference in measured dose is kind of optimal at this 1.8 sphere size. So this kind of confirmed our approach for using that detector size during patient-specific QA. And then finally, when we were going through those cases, we looked at the variation and where this is a problem. So based on the PTV volume, what you're seeing is the variation in the calculated dose dependent on the sphere size that you choose. So this is kind of the max variation across all sphere sizes. So what we kind of see here, I guess, for anything over 5 cc, it doesn't really matter what sphere size you use, and you probably don't need to worry about correction factors. When you're down in this region, certainly under 2.5 cc, so probably not spine saver in this case, unless you've got a small GTV that you're trying to boost. But you can come down to these for SRS cases. It is probably quite important to consider these correction factors. So we concluded that, yeah, the statistical noise is still a problem that we knew, and volume averaging is an appropriate way to deal with it. We did derive correction factors for most field sizes and identified that this is really an issue for very small patients, very small targets only. And we found some ways to best model the CCO1, CCO4, which helps us increase our patient-specific QA process accuracy. So the next thing I'd talk to you about is this distributive patient-specific QA model. If you don't have a physics background, when it comes to Sabre spine, we know these are some kind of really complicated treatment plans, and often the complexity of the beam segments and the sequencing is up there as one of the highest that we do in radiotherapy at the moment. And as a result, we run patient-specific QA processes on every patient. And that generally consists of measuring the plan in a known geometry with some kind of known detector. We use this SRS map check in Genesis. I think we've got one in Charlie's now. So this is a small array. So this is a kind of sort of 70, 80, or 77 millimeters by 70 millimeters. And it has 1,000 detectors in there. So we can get this high resolution map. We measure the sagittal plane. We look at the kind of PTV dose and the drop off into the cord in this direction. And what we end up with then is some kind of map that looks like this, where we have a kind of PTV dose and we can see the cord fall off as we go. And we get these little blue spots if something's too cold, red spots if something's too hot compared to expectation. Now, what we do as we measure this, and we've always measured these, and we'll normally measure this on the machine that we expect the patient to get treated on, because we're kind of trying to confirm that the treatment machine is delivering the dose that we expect from the TPS. What we would like to investigate, or we did investigate here, is a kind of distributive patient-specific QA model. So this is a situation where you might have a range of Linux that are all matched to a single treatment beam model. And in theory, what we think is that all of these machines deliver the exact same dose and the exact same time because they're held to the same tolerances and the same baseline values. But we know when we get to this level of complication, small Linux calibration issues can cause quite big dose differences in delivery. But what we wanted to know is if we could use different machines to treat the patient. So if we could have different fractions across different machines, and if we did that, do we need to measure the plan on every single machine, or can the measurement on one machine be representative of the dose delivered on another? And it provides us a lot of benefits. It improves our workflow efficiency, improves our flexibility and kind of resilience if Linux go down or get damaged. It also means if someone isn't available at a regional site, or if one piece of equipment breaks or we don't have as many pieces of equipment as ideal, we can still get patients treated in a good amount of time that's beneficial for them. So the plan was to evaluate the similarity of some delivered doses across a range of LINACs, determine if any variations in those deliverability are consistent or if they're kind of LINAC specific, and then look at the kind of safety of a distributive QA model like that. If we do it, how likely is it that we measure something that on one machine that says it's safe to treat, but then actually the treatment machine would misdeliver the dose? And to do that, we first had to kind of define what we mean by how well we would like them to be matched, because it isn't necessarily a well-defined thing. So I won't just read these out to you, but we'll come back to them as we go through. But we're looking at kind of the range of patient-specific QA results across machines and the range of dose difference that we see. So we took 10 of our clinical treatment plans, these are our last 10 patients across a varied range of treatment sites and some different optimization processes, I guess, and with some kind of slightly different complexities, but they cover the rough area that we're looking at. And then we made sure that machines were matched to these tight tolerances. These are the Genesis matching tolerances, which is relatively tight, tighter than the Elekta defined tolerances, but they're what we work to. And then we measured each of these plans on, I suppose, a total of 12 LINACs across 11 different sites, according to a well-defined protocol. So we looked at what would happen in each case. The first thing we looked at was the kind of plan-to-plan variation, and we looked at some different gamma criteria, because it's not always inherently obvious which criteria are most applicable to these cases. And what we saw is that there was a variation. So some plans like this one, every machine passed the plan very well. And then other plans had a lot more variation between LINACs. And then over here, we looked at the different LINACs. And again, we saw there are some LINACs where everything passes really well, like this LINAC number 7. And then there are some which have really variable results, like LINAC 12. And what we could also see is that the two worst LINACs here are kind of quite different from the rest, which reflects on this as we go. But what we could see is that for 3% 2 millimeters, we didn't see any fails across any machines, which is one good thing to take away. But at 3% 2 millimeters is also the only case where the standard deviation across the measurements on all LINACs for a given plan is less than 1%. So when we start moving into this 3% 1 millimeter or 2% 1 millimeter, we start to see that the ranges increase somewhat drastically, and we no longer meet that 1% tolerance that we were hoping to achieve to call our machines matched. The next thing we did was overlap all of these dose distributions. So this is a kind of TPS, and this is like a 2D bar chart, if you like, of the rate of failure of different plans. So the brighter the color, the more LINACs that failed at that point. So what we can see is in here, for example, we have an area where pretty much all the LINACs failed at that point, which suggests that this is probably not a LINAC issue, but this is a TPS model, and we could potentially fix this up. All these areas where we've got the blue kind of markers where only 1 or 2 LINACs failed is showing a kind of variation in LINAC distributions, and these are kind of inter-LINAC variabilities which we might be able to solve by increased matching. But they're the points that we worry about in a distributive QA model. The bits where everything fails every time is actually not such a problem, because it means we're not going to get our false passes. But generally we can see that most things are LINAC specific. So from there, we followed through with a kind of assessment of the distributive patient-specific QA process. So we looked at when we might get false passes, false fails, true passes, and true fails. So as we saw earlier, at 3% 2 millimeter, everything passed all the time, which means we would be very safe in doing a distributive QA model. Things are going to pass or fail on the same machines. when we fell down to these 3%, 1 millimeter, 2%, 1 millimeters, we started to see significant enough rates of false QA results that we decided we wouldn't apply this process. So what we could take away from that is that high quality beam matching to tight tolerances does allow us to do distributed QA across the necks and to move patients across their necks. But we only would run this if a gamma criteria 3%, 2 millimeters was appropriate. For cases that require tighter gamma criteria than that, we didn't feel that it was appropriate, and we wouldn't do that for those cases. So for SRS brains, SRS spine for us, we still measure on the treatment machine. All right, and I'm aware my time's getting on, so I'm going to go through this last little bit pretty quickly. So the final bit was spinal stabilisation implants and SBRT. So for those that have worked, we know that in radiotherapy, we know that metal in the patient gives us some artifacts, and it makes dose calculation a bit more challenging. More recently, there are these carbon fibre reinforced implants that can be used. So they have a carbon fibre structure with a very thin layer of titanium just to support them. And these have essentially been designed with radiotherapy in mind because they provide less imaging artifact and should allow more accurate dose calculation. So target delineations, one thing that can be affected by that, by the issues associated with the imaging artifacts. Now, we didn't really investigate that because fundamentally, if the images are higher quality with less artifact, then the target delineation should be much easier, and we didn't really feel the need to evaluate that. What we wanted to look at was how well we could localize patients and how accurate the dose calculation was in the presence of both these titanium and carbon fiber reinforced implants. So the first thing we needed to do was make a phantom. So we 3D printed some test samples, took some CT scans, and then made some measurements of their attenuation and MV beams. And from that, we could determine a range of points here. So this is reasonably complicated, well, reasonably detailed chart, so I won't go through it. There's a couple of materials. But what we managed to pull away is a reduced infill PLA, and then a stone fill PLA would allow us to generate tissue-like materials and bone-like materials. We then used a dual extruder 3D printer to develop this modular based phantom, which had some ionization chamber inserts and some film inserts. And we created a series of phantoms. So we had a spine phantom, and then we had two spine phantoms, which had different areas available for screws and implants to be inserted. We then did an evaluation of them. So we CT scanned them and looked at the Hounsfield units present in those items. And what we could see is that even though we were using the exact same settings and print quality, we still saw sort of variations of plus minus 50 Hounsfield units in the mean value, with a relatively standard deviation. So the density just sort of seemed to vary a bit with different prints. And a similar stuff happened in the bone region, but the densities were quite comparable to bone, so we were happy enough to use it. We also were able to evaluate the geometry of the developed phantom by testing how well some auto contouring showed the comparison to the 3D print design. So we basically fused the scanned phantom with the design and contoured the bone, and we could see that the agreement was very high. So to then assess these implants, we did a couple of things. So we first looked in some heterogeneous medium. So we used a 3D scanning water tank to scan behind these titanium inserts and behind the carbon fiber based inserts and generate some profiles. And then we did the end-to-end testing with this phantom that we generated. So at the top here, we've got carbon fiber screws, we've got 0 screws in image C, and then D and E are the titanium screws. And we compared the results when we used MAR, so metal artifact reduction, and when we didn't, to kind of evaluate all the options. So the two things that we evaluated were end-to-end dosimetry in this case. So we generated some treatment plans and measured them with ionization chambers and with film. And we also looked at the localization accuracy. So we positioned the phantom using our clinical workflow and then evaluated whether a ball bearing had been put correctly at isocenter using a Winston-Lutz test and this PIPS Pro software. So the results were probably as expected. The titanium has a kind of really quite severe impact on the dose distribution or on the beam profile and fluence. It can cause up to sort of 10 to 12% attenuation within the immediate proximity. And that reduces down to probably only 4 or 5% once you're 2 centimeters away. And we also see this increased scattering very close to the screw in the lateral directions as well, which we know is from the increased scatter from the titanium. So the dashed lines here show what the TPS predictions were, and the solid lines show the measurements. So even though the titanium was pretty impactful to the beam, we also saw that the TPS handled it surprisingly well. And we saw kind of only 1 to 2% variations in the doses. So we were pretty pleased with how well the TPS could handle it anyway. These charts are not great for a presentation, but essentially what we've also found is that using either ExactTrack or the XVI system on the Linux, we could position the patients with sub-millimeter accuracy with a maximum deviation to being 0.3 millimeters. So definitely these artifacts are there, but they're not affecting the fusion and localization of patients. Then we looked at the end-to-end test, so we measured the doses, and we looked at the patient-specific QA results as well. So what we saw was that for the phantom with no implants, the carbon implants, we saw a very good dosimetric agreement, always sub 5%, generally sub 3% in those cases. And when we saw titanium, we still saw reasonable agreement if we use the MAR scan. But once we lost the MAR scan, we started to see pretty big deviations. What was also particularly interesting was this, is that we saw the patient-specific QA results drop off when patients had been planned with a titanium implant, even though the titanium itself is not present during the patient-specific QA process. And then we looked at these film doses. So this was a final part of the study. And this comes back to the image we saw earlier. So up in this top right-hand corner in image C is no implants, and we can see relatively smooth dose distributions. There's no major discrepancies in the scale. So these kind of greeny areas are pretty much correct. With the titanium implants on the bottom row there, you can see quite clearly where the screw position is down the middle of the spinal target. And when the MAR is not used, we can see pretty large discrepancies, up to 10 to 12%. So we definitely wouldn't recommend doing this without MAR. The carbon fiber with the MAR gave very similar results to a blank phantom. So we can see that that's very good. And then the titanium with MAR or the carbon fiber without MAR gave good results that were slightly decreased from a no implant situation, but both clinically acceptable. So from that, we have concluded that spine saver is feasible in the presence of implants as long as you use appropriate corrections. So for the carbon fiber-based implants, we get reduced imaging artifacts, the dose is less perturbed, and the positioning is slightly less accurate. And if you don't have MAR, then you can still probably do spine saver to some clinically acceptable tolerances. With titanium implants, the images are definitely worse. But if you have a good MAR algorithm and you can accurately correct for that MAR, that titanium, then you can still deliver spine saver accurately. And then so clinically, if you get the choice, you'd go with the carbon fiber ones, but if not, you can still treat these patients. And then to try and come back to those fundamental underlying aims, so for Monte Carlo calculations, we can implement that in the spine saver and also the long SRS brain space. And we've defined some criteria that you might use in some planning settings that are appropriate. We managed to kind of successfully show that small field commissioning, or improve the efficiency, I guess, of small field commissioning in a clinical setting, and also highlight where that method is limited and what you can do to get around that. We also use that technique to improve our patient-specific QA processes. And then high quality Linac matching is allowing distributed Sabre QA and distributed Sabre treatments, but we feel it's only appropriate for patients where gamma criteria 3%, 2 millimeter are appropriate. And underneath that, then we still see too much inter-Linac variability that we would like to independently evaluate delivery before treatment. And when it comes to spinal implants, we're kind of happy to treat these patients now, assuming that we're applying the correct MAR algorithms and determining the location of the titanium accurately enough. So at that point, I'll stop. Pretty much running out of time. A bit of a flyover of the last few years. If anyone's got any questions, feel free.